All right, I'm going to get things started. As I mentioned, welcome on behalf of SCG and EPIP-LA to our funders briefing on the COVID-19 vaccine. Thanks all for getting the chat buzzing. Just want to introduce myself. I'm Charlotte. I'm part of EPIP-LA. I'm on the steering committee, and my two other committee members are here, Mary Cruz and Saul Valdez. They'll be in the chat too. EPIP-LA is a network of early to mid-career professionals. We're committed to a more equitable and inclusive philanthropic sector. And we're so excited to be co-hosting this with SCG today. At the beginning of our EPIP meetings, we usually just take a mindful moment and read aloud our grounding language. So I'm going to do that. We'll just take a minute and then we will get on with the show. So I know you're off video, so you can look at me, or if you can close your eyes if you want. It's Monday morning. So if you want to sit up, kind of move your shoulders from your ears, close your eyes. We're going to take 3 deep breaths together. We're going to take our first breath, a deep inhale through our nose, and a deep exhale through our mouths. We're going to do that 2 more times. Relax into your chair. Try and empty your mind. And have a deep inhale through your nose, and exhale through your mouth. And one last time, a big inhale through your nose, and an exhale through your mouth. All right, if you want to flutter your eyes open, bring your focus back to the screen. We've got a long day ahead of us. So it's nice to just take a minute to kind of ground ourselves and calm ourselves into this moment and appreciate the panelists and the work that we're going to be hearing about. And I'm also going to read our grounding language. We gather here today intent on doing good work. We are grateful to be on this land, and we acknowledge the Tongva and Tataviam tribes for which this land was taken, and all those who were displaced from this place. We acknowledge that it is a privilege to serve our community and are committed to using our resources fairly as we build authentic relationships and hold ourselves accountable in striving for a common good. We recognize the place we take up and are mindful of our voice and the voices of others. We express our gratitude for the diverse opinions here today and remain open to all ideas and beliefs. And for those of you who aren't in LA County with me, I'll put in the chat, you can find where your native land is here if you want to have a look at that too. All right. Well, usual housekeeping Zoom rules. Questions in the chat, please mute yourself. And I want to hand it over to Rose Venegas, who is the Senior Program Officer at the California Community Foundation, to keep this going. Thanks, Rose.
Thank you very much, Charlotte, and thank you to the EPIP organization as well as Southern California Grantmakers for the opportunity to have an important conversation today with some excellent speakers. Welcome to the Southern California Grantmakers Funders Briefing on the COVID-19 vaccine. I have the honor of being joined today by several panelists who have statewide and national reach with regard to the COVID vaccine priorities that are being set here in Los Angeles County with Orange County leadership and with other counties here in Southern California. First, I'd like to share our first panelist will be Ms. Isabel Becerra, who is the CEO of the Coalition of Orange County Community Health Centers, a network of federally qualified health clinics, as well as their other health provider partners serving Orange County. We're also joined by Dr. Oliver Brooks, who's the Chief Medical Officer with Watts Healthcare Corporation and currently co-chairs the California COVID-19 Draft Guidelines Work Group, leading discussions around equity and the prioritization of individuals with various chronic health conditions. And third, we have a panelist who is the Executive Director, Ms. Aquilina Soriano Versosa, who's the Executive Director of the Filipino Workers Center, one of the bright lights in terms of mutual aid networks operating here in Southern California and serving multiple counties. Once again, I'm Rose Venegas. I'm a Senior Program Officer with the California Community Foundation and most recently served as co-chair of the Aligning Resources for Mass Vaccination Committee of the LA County COVID-19 Vaccine Work Group. I appreciate the time and the gifts of talent and treasure and wisdom that our panelists will share today, and welcome your thoughts as we move into what I know will be a dynamic conversation and an opportunity to ask a few questions of our expert panelists today. So I turn it back, I think, to now each of the panelists. We will have opening remarks from each speaker, beginning with Dr. Brooks, then with Ms. Becerra, and finally with Ms. Soriano Versosa. So Dr. Brooks, I know that you've seen quite a bit in terms of the state actions and decisions with regard to vaccine accessibility and equity. And I open it up for a few minutes for you to share some opening remarks.
All right, well, thank you very much, Rose, and happy to be here with you today with grant funders. So I have two roles. Again, my first role is the Chief Medical Officer at Watts Healthcare Corporation. So I'm here in the community dealing directly with the issues that we are addressing. And right now the focus is on the vaccine, and that makes perfect sense. We worked hard to get a testing site up, and now we're having to shift over to vaccinating, but that's how it is shifting. I mean, I gave a talk where I said, everything I'm saying today may be old news tomorrow. So we all have to learn and grow. So I'm gonna speak first what we're doing. So right now at the Watts Healthcare Corporation, we got our vaccine, and we were designated to vaccinate our staff. And we worked on our staff, had some vaccine hesitancy among our staff. Now we're moving toward the 65 plus, and then as of today, we can look at the three working sectors: education, emergency services, and food and agriculture. We will be going live with that side this Saturday, March 6th. So we're doing it in real time. As it relates to the concerns, the issues, as you stated, I'd say the one thing we are not realizing well yet in this state is the equity lens of vaccinating. About 3% of the vaccines in our state have gone to African Americans, and we're about 8 to 10% of the population. And there has been a hard drive to get it in terms of an equity lens. Working with the drafting guidelines, our plan was looking at those workers, after healthcare workers in those long-term care facilities that had the highest societal impact, exposure at work, equity, which is a broad subject, a broad umbrella, and then influence on our economy. But that became a challenge. And I think that's when the governor shifted to 65 plus, but then there was kind of an outcry that we weren't hitting equity. So now we're moving forward with these particular sectors. And we're hoping that that does get to equity as of March 1st. Challenge logistics, and then hesitancy. So we're working now to get all these logistics straight. You know, there's CalVax, then we have PrepMod that is morphed over to My Turn, and now we have a TPA that's managing it. So again, the goalposts keep shifting, but the desire is to get the vaccine in the arms in the most appropriate fashion. So that being stated, we understand this and we're moving forward. Our most innovative step right now is that we have partnered with the East Bay Community Foundation that was funded through the Congressional Black Caucus Foundation and the Kaiser Family Foundation, where we have a grant where we have MOUs with other organizations, Holman Church, the YMCA, Charles U University. The goal is to delineate, to find out, to ascertain the knowledge, attitudes, and beliefs in our local community regarding vaccine, testing, treatment, and general COVID-19. There are 8 others, and they're different geographic areas throughout the country. So we're going to do focus groups, then we're going to do and surveys. And with that information, we have targeted messaging based on what we find in the South Los Angeles community. Also to that end, we're trying to get with influencers. So there is a rapper named Styx who is well known in Watts. He actually interviewed me on Friday. He interviewed me. So he is vaccine hesitant. He listens to conspiracy theories. And his position was, okay, Dr. Brooks, you're respected. I'm gonna throw everything I have at you. So he recorded it and he's gonna post it on his own social media because to go directly at what the knowledge, attitudes, and beliefs, and we may even call them misperceptions, but I just call them knowledge, attitude, and beliefs. And then as it relates to, so what do we do? I mean, if there are those that have funding and there are all these issues out there with equity, with the supply, with allocation, vaccine hesitancy, I would say start first with those that are doing what you already know needs to be done. So I was chair of the clinician advisory group for CCLAC, the analog of what Isabel is doing down there in the OC. Support CCLAC. CPCA is in direct communication with the FQHCs, with those that are promoting vaccine. And then I know there's thought to promote and support the mass vaccination sites, but half of African Americans receive their medical care from the solo and small group practitioners. So I think there should be a way to evaluate and determine how we can best support those that where people can get the vaccine from their own physician, because that's where the discussions can also happen as it relates to messaging. Um, so I would say that. And last, I'd say fund innovative ideas, and maybe not large sums, maybe $10,000 to $50,000 for people that come up with ideas that'll get these vaccines into people's arms. You know, there's Dr. Jerry Abraham working out in Kedron. He's done a great job. He did it on his own. If he had an extra $50,000, he could have done a lot more, I imagine. So I will stop there and just kind of give a broad statement of what's going on with me personally from the two areas where I come from, the vaccine and the CMO in the South LA community.
Thank you very much for your comments, Dr. Brooks. And I see a future podcast ahead for you, Talking Trust with Sticks and Dr. Brooks. So I appreciate your sharing your thoughts on innovation and working with communities where they are willing to hear the messages. I want to turn next to Ms. Isabel Becerra. And please, Isabel, if you could come off mute and share some thoughts about opportunities for colleagues in Orange County.
Thank you. Thank you so much, Rose, and thank you for having me here. I feel so privileged and just great to be in front of a group that I know is going to be receptive to what we have to say in terms of equity and the distribution of the vaccine. So I represent the community health centers in Orange County. There are 12 consortia like my own up and down the state of California. And so we're all dealing with the same issues. And we all know that as though COVID has had the ability to impact anyone across the world and respectively the nations and its individual states and jurisdictions, it continues to highlight in practice that the virus behaves like many others and that it's impacting the most vulnerable in our society because they are the most exposed, the most fragile, and the more ill. So we continue to see through this pandemic that COVID has exposed the longstanding structural drivers like the precarious and adverse working conditions that our hardest impacted communities face and deal with on a daily basis. And again, these happen to be the patients that are being cared for at the community health centers. The economic disparities and the access to health insurance. It's as if, in my opinion, community health centers, because of the way that they were designed, opened, and funded over 50 years ago, they were strategically placed to respond to conditions and situations like these. And these important determinants of health, as we know them, have interlinked with class, ethnicity, and gender, education level, and other factors. Now, when the pandemic started for all of us, I think all of the providers that were already in the community serving these hardest hit families and residents, they pivoted very quickly, pivoted to respond not only to their ongoing healthcare issues and concerns. We didn't close. We converted to the telehealth capabilities. We quickly worked with our local healthcare agencies and determined how do we prop up testing sites, because at the time that's really all we could do. There was no vaccine, there was no treatment as there is today. And so we quickly pivoted. As we continue to move down the path of maybe that light at the end of the tunnel with the vaccines, we were also very nimble and quickly pivoted. Later on in future talking points, I want to talk to you specifically about what we did. I think my point here is that as community health centers and as trusted entities in our community, we are strategically located not only to do the testing, to do the treatment, to do the education, but also to do the vaccines, because we're trusted entities. We are already working with these hardest impacted communities, and we have those connections and relationships with the community-based organizations where we can bring additional individuals, again, to be vaccinated in areas where they either won't be standing in long lines, they won't be recovering or being observed, if you will, after vaccine under a tent, where they will not be canceled appointments due to weather conditions. And I'm not saying that all of these various ways of getting our communities vaccinated are good. I think we need all of it. We need a multi-pronged approach in order to really get to the herd immunity we're looking for. But if we're really talking about equity, and we're really talking about how do you get to those individuals that are not going to have the capability to access all these other locations and the tech savvy that's needed in order to sign up to either Othina in Orange County or Premod or My Turn, we need to continue to turn to trusted entities within our community. Thank you.
Thank you very much, Ms. Becerra. I appreciate your comments and thoughts around community health centers being also part of that trusted network of partners with whom we can partner to ensure equity and access to vaccines. I turn next to my colleague, Aquilina Soriano Versosa from the Filipino Worker Center. And Aki, if you could share a few comments around what you're learning about vaccinations, bright spots, as well as opportunities that still need to be addressed.
Thank you, Rose. And thank you for this opportunity to be here with this, with my colleagues on the panel. We're a bit of a different organization because we are a community-based organization, and we are really working, vaccinations and the medical field was not our main focus, but we have a deep base with those that are being, impacted. So at Filipino Worker Center, we work with low-wage Filipino immigrant workers, especially those who are domestic workers or work in home care and long-term care services. And these are some of the very vulnerable people of color, essential workers who are being impacted. And so we also work together in coalition with other organizations through the LA Worker Center Network and other coalitions who are also working with other essential workers who are very difficult to build connections to. Especially thinking about our immigrant population, especially those who don't have, who are undocumented, but are still, key parts of our communities and our workforce. So Filipino Worker Center, we were able to be a part of the Community Health Worker Outreach Initiative together with the California Community Foundation and the LA Department of Public Health, where as a collaborative of 6 different worker centers, we were able to hire, train, and mobilize over 100 community health workers. Our members who are peer advocates who work in these industries, so really understand the issues that people are facing. And with the training that we were able to give in partnership with the Department of Public Health, able to get out really critical information, connect them to critical resources, as well as things like PPE that many of them are not receiving at the workplace. And now that the vaccination has rolled out, through that process, we've been able to engage together in spaces like the Aligning Resources committee that is giving recommendations on the vaccine rollout. And I chaired the Essential Worker Subcommittee, and looking at what the challenges are. What are the gaps in terms of really rolling this vaccine out with equity? And we have seen some big gaps. Even amongst those who were eligible, there's a gap in terms of understanding who is eligible, and just a gap of getting the right information. And as was mentioned earlier by Dr. Brooks, messengers matter, and messages matter also. Having targeted messages that really meet people where they are, and having messengers that they trust is truly important. And we need to get to more refined ways of like where people can have real conversations and hear real conversations from people that they trust. We've also seen senior immigrant workers who qualified after age of 65. There are many essential workers that are over the age of 65 and don't have the retirement capabilities or the ability to retire. So they are continuing to work in grocery stores, in warehouses, in long-term care facilities. And there's been a technology gap, like was also mentioned, in terms of being able to both have the time to figure out where there are open appointments, as well as just navigating the technology of it. And that's posed a real barrier. And we have seen where even the setup, because of language and technical ability, that's also proven a barrier for them to show the right documents that they are truly eligible for the vaccines. And we've seen people turned away from sites even after getting appointments. Some of the bright spots that we see are really that, one, there is an investment in community health workers and in local institutions like community health centers that are clinics that are key institutions in our communities that already have relationships. We've also seen, as we are doing our outreach and able to provide financial assistance and education, we actually have grown much deeper the networks that we have within the communities of particularly vulnerable communities, which we are using not just to get quick assistance to, but using to build longer term relationships in the community so that we can build more long-term resilience as things continue to shift and continue to change. And our folks are going to be in crisis for a while, even through the recovery. So it's important that we're building in more lines of communication and more lines of support to our community through this whole process. And so some of the key opportunities that I see for philanthropy is really to have a lens around equity. There's been some, over the last week, there's been attempts to really partner with community organizations who have deep roots in the community, to have specific codes to provide that access to appointments for communities that have not been receiving the vaccine, even though they're disproportionately impacted. And this is a good strategy that needs to continue. But we also need support for these community-based organizations to have the infrastructure to scale out what they're doing. One, to maintain their operations through the different projects that pop up, but also investment in things like infrastructure, databasing, and even communications technologies that help them to maintain the scale of what they're doing with the community, so that what's being done is not just has both the short-term impact, but also a long-term impact as well. Thank you.
Thank you very much for your comments, Aki, and I appreciate what you're sharing about individuals who, because of their income status, may not be able to work from home, or may also have challenges with regard to accessing vaccine because of the lack of access to the internet. We know that the access to steady Wi-Fi signal is one of the barriers, but also the ability to wait on a phone line, even if you're not trying to get online and use the internet to register or sign up for a vaccine appointment. So I appreciate your comments on that. Thank you very much to the panelists for your framing comments. I want to offer right now, as we move into the discussion portion of our agenda, a bit of framing in terms of the work that lies ahead of us. So not just the work that's being started this week with the new availability of a third vaccine candidate, but also learning from what we've seen so far and how to address equity and the value of volume. If I could, I'm going to share my screen right now in terms of thinking through what might be the volume and value issues that we'll want to consider as individuals who are involved with vaccine distribution and equity. What you see here, and apologies to, I think, my Greater Southern California colleagues, I was able to locate some mapping indicators looking at where we might want to think about volume and equity as we address vaccine accessibility here in Los Angeles County. On the left-hand panel, what you'll see is a graphic from the Phase 1B distribution plan for Los Angeles County. And what this map represents is a geographic display of where individuals who are 65 years and older, and as part of the early age eligibility that was announced on January 12th by then Secretary Alex Azar of Health and Human Services, and later adopted in the state of California and various counties. We were interested in vaccinating individuals who are 65 years and older. We're also particularly interested in California and through various counties in using equity metrics, including the Healthy Places Index, which is developed by the Public Health Alliance of California, which includes a half a dozen or more of the largest public health jurisdictions. What this map depicts is the intersection of 65 years and older and where the Healthy Places Index, which measures the likelihood that there will be needs for higher health improvements, needs for greater advances in transportation, voter engagement, and other key indicators of equity in society, is that there are particular regions shaded in the purple where there are higher proportions of people who are ages 65 years and older, and where the Healthy Places Index indicates greater health needs. What the map on the left shows is there's a distribution of areas where we may need to focus in terms of vaccine accessibility, especially if we want to get to volume with regard to individuals 65 years and older. On the right-hand panel, you'll see a depiction of where we might want to focus if we're looking at individuals 65 years and older who are undocumented. And the difference visually between the two maps shows a strategy based around distribution and dispersal on the left, and concentration and focus of aligning resources within select geographies based on what we understand around individuals who may not have access to regular health care, who may be reluctant to access health services. Recent data released by the Center for Health Policy and Research out of UCLA indicated that 1 out of 4 immigrant individuals chose not to use a health service or other public benefit in the past year because of their immigration status. And so I turn to my colleagues on the panel and ask a key question that I know we've been struggling with up and down the state of California. What are some of the strategies that you've observed that are trying to address the value of volume and the value of equity with regard to COVID-19 vaccine access? And I'll take it in reverse order of the panelists' opening remarks. So Aki, I'll start with you, and I will shift off of the share screen just so we'll be able to focus on your response.
Great. Thank you. And so it definitely is a fact that the way that the vaccine has rolled out has not been equitable, and that we do need to have interventions to change this. I do think that the shift to kind of away from the essential worker framework is problematic in terms of the equitable rollout of the vaccine, especially if we think about why BIPOC or communities are have been disproportionately impacted. So if we look at, many of these communities are like you said, don't have the privilege of working from home, so are required to be out and about in the community. And because of economic status, reliance on public transportation is also greater and puts them at greater risk, as well as both access to healthcare, but also I think really key are the housing situations. One, because we have such a crisis of housing in California right now, the overcrowding is a big factor that we've seen, that low wage workers are exposed more to the vaccine. So one, it could be these intergenerational houses. We've seen it with the Filipino community and other communities where there are so many people working out in the community, and this is where their home is their intergenerational house that has many people together, and that spreads to the whole household and impacts the whole house, and having multiple, sometimes multiple deaths in one household. But also there are many low-wage workers that are just living in boarding houses with many different roommates. We see, home care workers that are living in a boarding house of 16 workers sharing, 2 restrooms and 2 kitchens, and so these are the conditions that are actually spreading it faster in and more disproportionately in our communities. And so we need to make sure that we understand that framework to then shift and make sure that those who are essential workers are prioritized in this process and that they actually have access. A lot of people don't know how to actually use their paid sick leave to then go get a vaccine as well. A lot of employers are not offering that and sometimes even make it difficult for them to access. So I think there's also needs to be an emphasis on workers' rights, especially in regards to being able to access healthcare, being able to safely quarantine, and be able to go get the vaccine. And just lastly, I would say as I said before, continue to support, targeted access to sites where community groups that can help people to sign up can actually have spaces and access to sign people up to get the vaccines. And ideally, if there are better settings than the forum, just because there's also has a kind of militarized feeling to it sometimes, like especially immigrants who are undocumented. We've had people go there and turn around because it's such an intimidating scene. So being able for us to be able then, and especially with this new availability of the third vaccine option, hopefully really being able to see how more availability in communities can happen alongside with the larger pods as well.
Great, thank you very much, Aki. And I'm just a few minutes from Dodger Stadium, and now I have a view of it as a Dodger militarized zone, thanks to your comments. But want to shift and ask Isabel. One of the comments that Aki just shared is this idea that volume and equity, if we think of essential workers and individuals who can't, work from home, we can get to volume and equity by thinking of working specifically within those very important clusters of essential workers. Now I see in Orange County, as the prioritization for vaccine distribution is rolling out, that looking at work settings is an important area, but also looking at living environments, whether congregate facilities or long-term facilities. I'm curious, given the community health centers that you lead, how you see volume and equity coming together, or perhaps not coming together, given the ongoing rollout of vaccine in Orange County.
Thank you, Rose. I would start by acknowledging the fact that we still have a supply versus demand issue, right? Even if we were doing it in an equitable fashion, we are still not getting enough vaccine for the need that we have. So for example, as advocates in Orange County, we first wanted to understand Where are the vaccines coming from? Where are they going to? And why are they not going to the right places? So we quickly then learned that there's a whole algorithm for how they come down to the local levels. There are entities like multiple county entities, MCEs, that get their own share, aside from what the healthcare agencies get. Then you have the CVS and the Rite Aids of the world, right? And they come with their own separate rules. And so when we figured out that any potential vaccine that could come to community health centers, for example, we needed to dip into the healthcare agency's supply. And for that, we made a very strong push for those vaccines coming to the community health centers. Once we understood how to get them, then we got into the math. So the county, out of the pool that we draw from, they get 40 to 50,000 vaccines per week. We have 3 million individuals in the county, right, give or take. And so in the community health center world, we care for 400,000 individuals on an annual basis. And so I was asking for 400,000 vaccines. I got 15,000 vaccines. So I knew from the get-go, we are not going to have enough. And at this slow pace, we're not going to get the volume that we need to in order to achieve herd immunity. So after we understand that, then we at least we can be a little bit more targeted and more sensible in the request and understand who do we push. Maybe not the local healthcare agency folks, maybe we go up to the state. And so we are also working with our statewide association to work on that aspect. We work with our National Association of Community Health Centers to work on that aspect, because now we have federally qualified health centers that are going to get their own direct supply of vaccines. And that's a great thing, although that too isn't thousands and thousands of vaccines. So we still have, the supply and demand issue. So I stick to my premise that all strategies are important. The large super pods in Orange County, we have the Disney pod in Anaheim. We have the Anaheim Convention pod. We have the Soka University down in Aliso Viejo. And so we say, those are not the places where the hardest impacted folks are going to go get their vaccines. They have to come to, again, these strategically located community health centers that they trust and that they know are not going to have ICE and or police there in the parking lots to direct traffic. We have volunteers. We have hundreds of volunteers that want to help us manage, these events, whether they be small or whether they be large. And we are also pushing for, let's not look for scapegoats here. There's no wrong shot. We understand that we have priorities. We focused on healthcare workers first. Now, then we moved on to 65 and older. We are not done. We're not done, obviously, with that population. But as today, we now have an opportunity to vaccinate essential workers like childcare providers, food and agricultural workers. We are pushing very hard, and the county has agreed that we will be using self-attestation verification, if you will, so that if you have individuals that are most likely maybe deterred from a system like this because they have to submit proof of where they work, they may not want to come to get vaccinated and therefore continue to work and continue to spread if they get infected. And so we were successful in doing that, again, with our partnership with the county, so that individuals like the taco truck folks, the ice cream truck man, everybody who works in the restaurant workers, the agricultural work that does go on in Orange County still, believe it or not, we want to make sure that those individuals have safe places where they can go get vaccinated. And I say that because I'm on the vaccine task force for the county, and every week we meet and we're always talking about how do we expand, how do we make sure that people aren't committing fraud. My biggest push is there is no fraud going on here. We should be giving everyone who wants the vaccine. We as smaller organizations should not be scapegoated as having done something wrong, when at the end of the day, you have 10, 20 vaccines that are going to go to waste if you don't provide them to somebody, right? Once you puncture that vial, you have to use it within a certain number of hours. And so it's not wrong for you to be able to draw from your lists or draw from the community. If we're doing, for example, vaccines at a local school, pull in the janitor, pull in the nutrition workers, pull in the people that are there that want to have the vaccine, so that, again, there's no wrong shot. Because of the vaccine hesitancy in our communities, I think that our role as medical facilities, it's an ethical question once you have to determine or make that call about, do you vaccinate this 23-year-old who is a what is it, a Postmates or DoorDash, driver, or do we that lives in Santa Ana, or that lives in Anaheim, that lives in a intergenerational, environment, or do we vaccinate, the 40-year-old, I don't know, small business owner from Huntington Beach who happened to call and ask for an appointment? Those are hard questions to answer, and so we want to make sure that the partnerships that we developed with those that hold the vaccines are such that are collaborative in nature, and that we're not, again, being penalized for example, vaccinating the wrong people. We understand there's a lack of vaccines. We're doing the best that we can and going to the through the tiers, and all we ask for is a recognition that if they really, when I say they, I mean the healthcare agency, local jurisdictions, if they really want to apply the equity lens in what they're doing, they cannot leave the CBOs and community health centers out of the mix, because without us, they cannot achieve equity.
Thank you very much for your comments, Isabel. And certainly, I think appreciate your sharing the example of self-attestation as an innovation opportunity. I know that Aki and I on the work group here in LA County looked to verifications processes that relied on individuals saying, I access services at a local community-based organization, as a way of verifying that individual likely is eligible. So opportunities for volume and equity. And turning, I think, next to Dr. Brooks, you really have the 30,000 perspective on this, given the drafting guidelines work group. And I'm curious how that group and under your leadership are looking at volume and equity in tandem, which we know we want to get to, especially as we now have a third vaccine candidate.
Right. So Isabel made a great statement. It's all about lack of vaccine. So if she had her 400,000 that she needed, we wouldn't be discussing this. So when you try to do volume and equity, you do have a challenge, because like there's states like Florida and Texas that anyone can get a vaccine. So you got instant volume, but no equity. And what we did here in this state is we focused really hard on the equity piece. I mean, we had meetings, 3-hour meetings, like 9 of them. But what happened is it is really difficult. So I think that to walk that fine line, the way that we should move forward is kind of a focus on zip code or geographic area, which really helps. I want to make one statement about age. If you look at your 2 maps, you could see that in LA County, the darker purple was moving a little bit more toward the west side, and areas that didn't really align with down the middle, which you had for the red that were the undocumented. One not often stated fact is the percent, at least in America, of African Americans that are 65 years and older is about 8.6, but of whites is about 12.8. African Americans don't live to 65 as much as others. So just inherent in having an age-based framework, African Americans had lack of equity. But it was practical, because it was really hard, as you are saying, self-attestation. Do you take it to the worker at the grocery store? How do you know that someone really is childcare? I take care of my next door neighbor's child in my childcare. So those were all the issues that were so difficult that the governor went to an age-based, and now is moving toward the essential workers and medical conditions, underlying medical conditions. So I think that the way you do it is you listen to those of us that are in the community. Tell me, I'll give you 1,000 doses instead of the 200 I'm getting, but I want you to be able to get it out there. And I'll give you 200, then I'll give you 400, and you need to give me a plan where you're going to hit the volume. Make me get with the local National Medical Association societies, which has solo and small group practitioners, directed to Isabel's people in Orange County with the community health centers and community clinic association of LA County. Get us the vaccines, and that has been happening. I want to say that this is not an abject failure. And there was a question, and the question and answer said, focus on not vaccine hesitancy, but vaccine acceptance. I think we need to have more positive messages in everything we do. So yes, we're not where we want to be, but there's a reason why. primarily lack of volume of the vaccine, but we are doing everything we can, almost everything we can, to get where we're going and accentuate the positive. And the last thing I'll say is that the more people that get vaccinated, the more there is vaccine acceptance. So my experience has been, even with my medical staffs, a lot of people were hesitant, but when they saw the other people getting vaccinated, it's going, well, wait a minute, maybe I should get my shot too. So I think that when you look at volume, the volume will come as the vaccine comes, as we keep pushing as best we can using this equity lens in the manner in which we are doing it.
Thank you very much, Dr. Brooks. And certainly this is a delicate balancing act. And as you mentioned, we're trying to walk that line back and forth between volume and equity. Volume when we have the doses, and equity when we decide how to use those doses with the communities that are most impacted. We have two questions in the question and answer. In fact, thank you, Dr. Brooks, for picking up on the question with regard to vaccine hesitancy and vaccine acceptance. Thank you to the community member who posted that question. Where I've heard some of the discussions at the federal level look at this issue of acceptance, confidence, and hesitancy is really making this point that over time, we will need to shift in our communication strategies. We are now in a phase of scarcity. We're looking at water in a desert in terms of the doses that are available. But when we get to the phase where we have water in a rainforest, we have 6 vaccine candidates and sufficient supply of doses, which I know many of us, all of us look forward to. We'll need to shift some of our communication strategies. But I don't know if Dr. Brooks or Isabel, you're also hearing that on the national calls that I know you're both on, that we're talking about vaccine hesitancy, folks who don't trust the messages, hence the reason why you're on a podcast or interview with Styx, the rapper, Dr. Brooks. But Isabel, we also hear this with regard to healthcare workers, where upwards of 40% of healthcare workers are opting not to accept the vaccine. So vaccine hesitance, vaccine acceptance, vaccine confidence, where do you think the communications need to be in the next month or so?
Jump in. We have also hosted several Facebook Live town hall meetings, both in English and Spanish. And what we find is that the vaccine hesitancy it isn't as real, or the numbers aren't as high as they're being projected. We found that once, your abuelitos, your grandma and your grandpa got the vaccine, that encouraged the younger folks to get it. And then you have the situation where so many of our community has tested positive, that there is the belief that once you've had COVID, you actually don't need the vaccine and you're free. And you don't have to get the vaccine. So we then started targeting our messages to bust those myths. So we have myth-buster sessions where we have community physicians answer questions from the community. And so for us, the issue continues to be lack of vaccines, because the minute that we get, for clarification, at the community health centers, we were able to negotiate 15,000 vaccines per week if we can burn through them on a weekly basis. Now that proved a little bit challenging. So we're averaging about 10,000 vaccines a week. The minute that we get them, they're already scheduled, right? And so we're not seeing the hesitancy as, as it's being portrayed in the media. We find that the messages from your peers is what's really driving whether you're encouraged or whether you're brave enough to go and get the vaccine. We found that when they saw providers that are, bilingual, bicultural, and they're able to identify with them, they're also then further encouraged, to walk down that line. So I think that we just need a lot of education and targeted outreach to these communities, and that they need to hear it from the trusted sources. And that's where the role of the community health centers and the community-based organizations come in, because it's a huge lift to do that for these communities when, for example, funding isn't there, when you need to add, additional FTEs to get that work done, when you're having to go around the county and do, sometimes, the Facebook Live and the technology-based forums are not working either because folks don't have access to it. So we've actually gone into the churches. We have specifically designated fully vaccinated staff that are not now going into the community where they're happy to do so. We're all tired of being at home. And so we want to go out and engage in the community so you can have that one-on-one or one-on-one discussions with individuals that can represent larger groups.
Thank you very much, Isabel. Dr. Brooks, vaccine hesitancy, vaccine confidence, vaccine acceptance. What do we need in the next month?
We need to accentuate the positive. We need to put messengers out there that are getting the vaccine, that are saying it categorically, I'm getting the vaccine because I don't want to get my abuela infected. I want to get vaccinated so I can get back to work because I'm a teacher and this is not the way to teach by a computer. I'm getting vaccinated because I just don't want to die. I agree with that, accentuating the positive. I also think that what's going to happen is as we get more and more people vaccinated, more and more people are going to want to get vaccinated. The other thing, which is crucially important, is face the people that are vaccine hesitant directly. Do not say, man, there's something wrong with your thought process. Why would you not want to get vaccinated? In the African-American community, there are legitimate concerns. I mean, everyone knows about the experiment that the government did at Tuskegee, Henrietta Lacks. I mean, it goes back to slave times where they would take bodies from the slave graveyards to have as cadavers. Black women were sterilized forcefully. Latinas were sterilized, last year in these detention facilities. So there are legitimate concerns, and the vaccine came out fast as an mRNA platform. Address every one of those concerns directly. Don't skirt around them. Respect these people that are vaccine hesitant and talk to them where they are. There's a document that I saw, a study where about those that are vaccine hesitant, a good 70, 80% of them are on the fence. So the person who won't, the person that won't get vaccinated under any circumstances, anything you say to them, they're even less and less likely. And then there are those of us that, I'm first in line. So focus on that group of individuals, which is the largest group, which is kind of what Isabel was saying. It's not as many as you think, and people just kind of say that reflexively. So that's, I think, is a crucial message. Look them in the eye, discuss their issues, say, I understand where you're coming from. This is why I would get vaccinated. It's your decision, but just, give yourself some thought based on the information the doctor, give to you.
Great. Thank you very much. It sounds like vaccine trust is an important concept that folks are raising on the panels. Really appreciate your responses to that communications question. We have a few questions here regarding federally qualified health centers. So I'll try to bring them together. So two questions. One question is, knowing that FQHCs or community health centers are trusted venues, how are FQHCs working with local communities that need to get vaccine, getting them vaccinated? And Isabel, I know you mentioned this a little bit earlier on, but if you could just recap that, given that there's continued interest in FQHCs and capacity, should there be, again, an increasing direct supply now potentially of the third candidate, Johnson & Johnson vaccine candidate that comes directly from the federal distribution route?
Thank you for that. So I'll also start by summarizing that collectively, and this may be the case in other parts of the state, the individuals 65 age and older as a collective is actually very small. It's anywhere between 5 to 10% of our total population. The majority of the clinic patients are over age 15. That's where you have the majority. And in fact, there's a cluster around between 30 and 55 is really where the large numbers are. And so we were able to finish with the 65 and older very quickly in early February. And so because we were still prioritizing and targeting that age group, we started to work with senior centers in our communities. We reached out to them and said, give me your list. We have 1,000 vaccines this week. Let's see how many we can get done this week. When we were done with that, then we moved on to the churches, because we know that not everyone is a patient of the community health center, but we know that everyone knows about that community health center down the street. And if that particular community health center is organizing a vaccination event, people want to go. And so we proactively reached out to organizations that we knew had lists. Today, the message is, have your list ready, because when we get vaccines, you're the first organization we're coming to. And so right now we have the fortune or misfortune of having very long lists from which we're drawing from. And none of these are coming from Athena or My Turn, because nobody goes to those, nobody has the time for that or the patience for that. And also there's a lot of multiple double entry sort of work that the community health centers would have to do in order to use that system and then document it in their own system to then upload to the state CARES 2 system. So we're doing everything legitimately, we just don't want to do it twice. And that's why they're not using these apps, and these systems to register folks. So we are definitely reaching out. I would suggest, if you, I know there was a question about a specific case. If you, I can be reached out to if it's an Orange County situation, but I'm sure any community health center in your region would be a great entity to contact to see how they can partner with their local organizations for accessibility for these vaccines for seniors.
Thank you very much, Isabel, and thank you very much to our panelists. We're now about 4 minutes away from the end of our session. There was one other question in chat, and I'll quickly pick up on that, but also pose the question to my colleagues here on the phone. What can philanthropy do as we look to the issues of volume and equity in terms of vaccine distribution? We now have 3 vaccine candidates: the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine. With regard to equity in the distribution of vaccine, the state has looked to the Healthy Places Index. And what you see on share screen is the link to the California Healthy Places Index, which is being actively considered in terms of the statewide discussions with regard to equity and distribution. We see the Southern California area. And if you would like to visit this website, we'll include it in the chat as well as include it in the meeting materials. How we get to our regions where individuals who have multiple health risk factors and come from vulnerable populations will be the true test of our humanity in the coming weeks, months, and certainly over the next year. We look to philanthropy, the doing greater good with the assets and resources to which we have access. Really, that's our mission. That's our charge as philanthropy. And so I ask each of our panelists to offer one idea, one bright, shining idea that they would like to leave this group here at SCG and EPIP with as we close. And Dr. Brooks, I'll start with you, then Isabel, and we'll end with Aki. One bright, shining idea.
Well, thank you. I would say go into the area where the zip code designation shows the highest rate of those that are at highest risk, those that underlying conditions, social determinants of health, essential workers where they can't work from home, and put a pot of money, again, not large, let's say 50,000. I need an idea from someone in this group, and look to a group like for us. I've partnered with the YMCA. They're all over LA. Say, I have $50,000. I need you to be able to get 50,000 people vaccinated in 1 month. Write me a program. You need to go out there and partner with whoever's in your area, but you give a specific amount of money and a specific goal and say, this needs to be done, this needs to be done. Let's say 30 days. Give us time to write our RFP. And something like that in that zip code area, I believe someone will stand up and say, I have this innovative idea. This will get it done.
Thank you, Dr. Brooks. Isabel.
Thank you. I would say that I would echo, Dr. Brooks' comments, and we call them strike teams here in Orange County. We envision having strike teams being readily available to organize and coordinate that vaccine event at the local elementary school, at the local church, because as much as we love our community health centers, they're going to get back to business very soon. Once they complete vaccinating their own patients, they have to worry about their sustainability. And they, as much as they want to continue to partner, and they will be the vaccinator, they have strike teams in terms of on the clinical side. They need the help on the admin side, the scheduling, the setting up, wherever we're going to be setting up. I never thought I'd be in the business of organizing mass events, and we have one this weekend because we were able to get, for example, 2,000 vaccines, and we were told get them out in Santa Ana in the 92701 zip code. That's exactly what Dr. Brooks alluded to. And now I'm scrambling to find, where do I get tables? Where do I get volunteers to help sign up? What color vests do we wear? That's not something that we're funded to do, So I think that strategic investments in communities that know their community, know how to get those things done and have good intentions and heart, I think we need funding for that, is what I would say. And I would go for higher than 50,000, Dr. Brooks. Let's go big or go home.
Thank you very
I'm
much,
I'm with
Isabel.
you on that. I formally withdraw my $50,000 statement.
We'll get into a bidding war next. Aki, you get to close us out. What bright, shining idea are you recommending philanthropists support?
And I think this is complementary to the other bright ideas, is invest in community health worker structures, like over the long term, even over the next year, like a stable investment in that. Because as these like opportunities open up, like suddenly there's a pod that has like 1,000 available. It's like those folks who are going to actually make it accessible by partnering with the individuals to get them to troubleshoot the transportation, to troubleshoot everything so that they can actually access that vaccine. They need to be there, and they can't just be pulled up and they can't be built overnight. We actually need them there so that we can take the opportunity when it arises, because it comes very quickly. But if you don't have that infrastructure already set up, it makes it so difficult to scale up and then scale down again and scale up, and just like not being able to maximize that opportunity. So invest in community health worker programs in community-based organizations that have deep roots in the community. Thank you.
Thank you very much to our panelists. I appreciate your time. I appreciate, we've also gone past our noon commitment, but really want to thank you all, Dr. Brooks, Isabel, and Aki. Really appreciate your time and the gift of sharing wisdom today. Turn it back to my Southern California Grantmakers colleagues and my EPIP colleagues to close us out.
Hi, everyone. Thank you so much. I'll just make one plug, which is that SCG's health funders will be hosting a follow-up conversation on March 9th to discuss in a more interactive way with cameras on. All of SCG members can be sharing what you're funding related to vaccines, any gaps you're hearing about, opportunities. So if you are inspired by this conversation as I am and want to network with your fellow funders and discuss next steps and how to turn all of these bright spots and suggestions from our panelists into action, please join us on 3/9. The link was put in the chat and we'll send it out with the follow-up resources from today's webinar. Thank you all so much. Take good care.